So today our lecture will be about hemolytic disease in newborns. Hemolytic disease in newborns is a congenital disease occurring in utero or in the first hours or days after birth as a result of the immunological conflict due to the incompatibility of fetal or maternal blood by erythrocyte antigens. Hemolytic disease is due to transfusion from the mother's blood through the placenta barrier of antibodies direct against the red blood cells of the fetus and the baby, which leads to their intensive destruction. The reason of the development of newborn hemolytic disease is pregnancy of the Rh negative sensitized woman with Rh positive fetus. Factors contributing the sensibilization is abortion, microcarriage, blood transfusion, previous pregnancies with Rh positive fetus. Uh, in the presence of Rh incompatibility of the mother and the fetus, hemolytic disease develops in one child from 2025 only. The most common development of hemolytic disease in AB0 system is observed in the presence of the mother, the 0 or 1, in the fetus, the A or 2 blood groups. This is due to the greater activity of antigen A. Hemolytic disease in the AB0 system can develop already at the onset of the first pregnancy due to latent sensibilization which occurs before the onset of pregnancy. It will be vaccination, eating animal proteins, infectious diseases, intestinal bacteria, and so on. Classification of hemolytic disease. Etiological factor or type of serological conflict is according to the weather system and according in the AB0 system and maybe according of antigens of other systems. The next is terms of clinical symptoms in utero and postnatal. The third, on clinical or morphological form of disease. It will be intrauterine fetal death with maceration. The next is edematose, dropsy of the fetus, then icterus, and then anemia. And severity rate, it will be mild, moderate, severe. And complication, it will be DIC syndrome, hypoglycemia, bilirubin encephalopathy, bile secretion syndrome, defeat of the liver, myocardium, and so on. Postnatal diagnosis identify newborns of risk for development hemolytic disease and evaluation of possible clinical manifestation, jaundice and or pallor of the skin, edema, hepatosplenomegaly, neurological symptoms. Treatment hemolytic disease is operative and conservative. Operative, it will be replacement blood transfusion, plasmapheresis, and hemosorption. Indication for replacement blood transfusion is heavy form of hemolytic disease with severe insensibilization, where we have positive Coombs test. Then the presence of bilirubin intoxication syndrome in newborns. The next, the level of bilirubin in umbilical cord blood is more than 70 micromolar per liter and more than 170 micromolar per liter for the first day. On the second day, more than 256 micromolar per liter. The hourly increase of bilirubin is more than about 8 or 9 micromolar per liter in hour. The level of hemoglobin is less than 110 grams per liter. Conservative therapy. Infusion therapy of purpose of detoxification, improvement of coagulation, elimination process of bilirubin, glucose brain from 30 to 70 millimole per kilogram the body weight. But now the most important it will be phototherapy. Under the influence of the light of certain wavelengths, uh, appears the transformation into the skin of toxic bilirubin cells into the non-toxic isomer YY, which is water soluble and excreted by the kidneys. In severe forms, hemolytic disease now we used intravenous immunoglobulins in dose from 0.5 to 1 gram per kilogram to conjugated these antigens and antibodies in the blood. The next, it will be preparation the adsorbed bilirubin in the intestine. It will be smecta and another enterosorbents, diuretic preparation, capitol, or 12.5% solution of magnesium sulfate, drugs that interfere with the development of bile consideration syndrome. Is the drugs from ursodeoxycholic acid, ursosan, polydexan. Sometimes in severe cases, different hepatoprotectors. So, replacements of blood transfusion. Indication for replacement blood transfusion. The level of core blood bilirubin is more than 60 micromole per liter. Hyperbilirubinemia is more than 342 micromole per liter, and the growth rate of bilirubin is more than from 8 to 9 micromole per liter per hour.